Good afternoon, everyone, and thank you very much for the opportunity to present our studies on nurse-led health promotion interventions for frail older home care clients. And I'd like to thank the Community Health Nurses Initiative Group, the Community Health Nurses of Canada, and the D'Souza Institute for the opportunity to present today. I'd also like to acknowledge our funders for these studies, the Canadian Institutes of Health Research, the Canadian Patient Safety Institute, the Canadian Health Services Research Foundation, the Ontario Ministry of Health and Long-Term Care, and McMaster University System Link Research Unit on Health and Social Service Utilization. So our program of research that I'm going to be presenting today was developed in response to really three major social transformations in the Western world. First, we know that Canadians over 65 years of age represent the fastest growing segment of the total population. And by 2031, about a quarter of the total population will be older adults. And as the population of older adults increases, so we see an increase in the prevalence of frailty. And about 15 to 20% of community living older adults are considered frail, and over 80% of these frail older adults have chronic medical conditions. At the same time, we've also seen an increasing trend toward aging in place. About 90% of older adults live in the community. And the result overall of these trends is an increasing demand for home care services for frail older adults. And these frail older home care clients typically have higher levels of disability, lower levels of health-related quality of life and support compared with the general population of community living seniors. Nurses play a key role in leading an interprofessional team approach to promote health and prevent illness or disease, chronic disease, and reduce frailty among older home care clients. And there's a growing body of knowledge that suggests that community living older adults can benefit significantly from individualized, nurse-led, home-based health promotion programs. However, the research on the effectiveness of these programs among community living older adults is somewhat limited and inconclusive. And in addition, there are multiple barriers to delivery of health promotion strategies in home care, such as limited and delayed access to professional home care services for health promotion, a lack of collaboration, interprofessional collaboration, limited follow-up care, and lack of appropriate assessment tools. So this information certainly suggests that there's a need for new and innovative health promotion strategies to enhance the health-related quality of life of older home care clients and their caregivers. So in response to this, we conducted a series of 3 nurse-led health promotion strategies. And these studies were conducted over a period of 9 years and they all evaluated the effects and costs of complex, evidence-based nurse-led health promotion interventions compared with usual home care for frail older home care clients using home care services. And the main results of each of these studies have been published, and I will be sharing those citations later in the presentation. So across these 3 studies, we had 4 common research questions. The first question was, does a nurse-led health promotion strategy improve health-related quality of life and functioning compared with usual home care services? Secondly, does a nurse-led health promotion strategy have a favorable effect on the components of frailty compared with usual home care? Thirdly, what are the comparative expenditures for health service utilization with a nurse-led health promotion strategy compared with usual home care services from a societal perspective? And finally, which subgroups of older adults benefit most from these interventions? And overall, our primary hypothesis was that a proactive and comprehensive, coordinated nurse-led health promotion strategy that was aimed at all of the determinants of health would be more effective and less expensive than providing services on a piecemeal, on-demand, and fragmented basis. So our interventions, our nurse-led interventions, were based on a conceptual model that we developed in response to a literature review on the concept of frailty. And this multidimensional model represents really the complexity of frailty in older adults. And it describes the hypothesized relationships between personal and environmental resources, which are essentially the determinants of health, and the use of health services. So specifically, we hypothesized by that by increasing personal and environmental factors such as social isolation, or personal resources such as decreasing depression or improving health or improvements in falls or so on, would actually reduce the level of vulnerability, which would in turn reduce the level of use of health and social services. So there would be a synergistic and cumulative effect between the reduction of both improvements of environmental support and improvements in personal resources. So that was our conceptual model that we used that underlined all of the nurse-led interventions. And all three of our studies were conducted through a university community research partnership that involved decision makers, managers, and health providers in 4 home care programs and 11 of the direct care provider agencies in Southern Ontario. And we used an integrated knowledge translation approach in that partners were engaged in all aspects of the research, and that included developing the research questions, implementing the intervention, interpreting the results, and then disseminating the findings. Each of the 3 studies were a randomized control trial where people were randomly assigned to receive the nurse-led health promotion intervention in addition to usual home care or usual home care alone. And our follow-up occurred at either 6 or 12 months following randomization. And we know that the randomized control trial is the strongest and most rigorous design for studies that measure effectiveness. Across the 4 studies, our inclusion criteria were very common in that they were older adults that were 65 years of age and over. They were eligible for home care services, living in the community, not in long-term care or in any type of inpatient facility. They were mentally competent to give informed consent or had a substitute decision maker available, and they also were competent in English or had an interpreter available. The primary purpose of the nurse-led interventions, which we consider here as complex interventions, was to promote health, prevent disability, and support independence in frail older adults using home care services by really proactively identifying issues and problems and people at increased risk and linking these people proactively to appropriate health and social services. So we define proactive or provider-initiated care as above and beyond the demand-led usual care. So in other words, it wasn't in response to a health problem or an event, but it was actually provided in a proactive basis. These were complex interventions that had multiple interrelated components, but the common features among the three interventions were that it involved a nurse who provided case management, monthly home visits by designated members of the healthcare team who received specialized training, risk factor assessment and screening. The interventions also were multi-component, based on evidence, and aimed at prevention and the detection and management of modifiable risk factors. There were formalized mechanisms for interprofessional collaboration, behavioral change strategies to enhance behavioral change and adherence to recommendations, referral and linkage to health and social services, and feedback of the results of the assessments to other members of the team and to the family doctor and other services in the community. So when we talked about risk factors, assessment and screening, we looked at the various components of frailty, such as falls. So we looked at risk for falls, nutritional risk, and depression and anxiety as an example. The data for the 3 studies was collected from multiple sources at baseline. That was prior to randomization or assignment to the intervention, and then we collected data again immediately following completion of the intervention at 6 and 12 months to determine the effects of the interventions compared with usual home care. And the sources of data we included in-home interviews, so we collected data from in-home interviews. We collected data from the community care access centers, the home care programs, and service provider agencies. Qualitative methods were also used to determine the feasibility and acceptability of the intervention, and that was conducted through focus groups with home care personnel that were involved in providing the intervention, as well as semi-structured interviews with older home care client participants of each of the studies. Across the 3 trials, we used a common approach to quantify the change in health-related quality of life from baseline to the end of the intervention, as well as we used a common measure to measure the cost of use of health services from a societal perspective, and that was the Health and Social Service Utilization Inventory. So that kind of gives you an overview of the 3 studies as a whole. So for the next part of my presentation, I'm going to go through and briefly summarize the results of each of the studies and then conclude with some lessons learned. So the first trial, which was the nursing health promotion for frail older home care clients, really the main objective of this study was to determine the effects and costs of a 6-month proactive nursing health promotion intervention compared with usual home care for frail older adults using home care services. The setting for this study was the Community Care Access Center of Halton, and the study population consisted of 242 older adults who were 75 years of age and over, eligible for personal support services through the CCAC, the Community Care Access Center. They were not eligible for nursing services through the CCAC, and again, they had to be competent in English, living in the community, and mentally competent to give informed consent. This particular study took place over a period of 4 years, and those clients who met the eligibility criteria were randomly assigned to receive either the nursing health promotion intervention or usual home care. This was a multi-component intervention that involved structured and planned home visits by an RN over 6 months. It also involved a nurse providing comprehensive in-home assessment of known risk factors for frailty using standardized screening tools, and then using the results of those tools to implement multifactorial evidence-based strategies to prevent as well as manage chronic conditions and reduce risk factors for functional decline and frailty. The nurse worked collaboratively with clients, their families, as well as the interprofessional team, and implemented empowerment strategies to develop goals and strategies to achieve them, to address behavioral change strategies that were required. The nurse also referred clients to community health and support services, as well as provided education and support. The primary measure of effect for this study was health-related quality of life using the SF-36 Health Survey, which we used in all 3 studies, as I mentioned earlier. The secondary measures of effect were depression, social support, coping, and we also looked at the cost of use of health services. And all outcomes are measured at baseline and again at 6 months using primarily a structured in-home interview. So in terms of the results, what we found was that compared with the usual care group, frail older home care clients who received the nursing health promotion intervention showed greater improvement in the mean SF-36 mental health component summary score and greater clinically important improvements in the mean SF-36 physical functioning score, suggesting that there were improvements in both mental as well as physical health. There was also a greater reduction in their depressive symptom score, suggesting a reduction in depression, and a greater increase in the social support score, suggesting that they felt that there was an improvement in terms of their social support. And even after the cost of the nursing intervention was included in the total cost, there was no significant difference between the groups in the total per person cost of use of health services over the 6 months. In other words, both the usual care group and the nursing health promotion intervention cost the same, so no more or no less. So those were the results of the first study. Our second study looked at falls prevention amongst older adults receiving home care. And we know that fall-related injuries are among the most common, morbid, and expensive health conditions involving older adults. And frail seniors are particularly vulnerable. About 50% of frail seniors with 1 or more chronic conditions have at least 1 fall per year, which is 3 times the risk of healthy seniors. And frail seniors are more likely to sustain serious injury, and they also take longer to recover after a fall. Yet there is very little known about the best way to provide home care services for the preventive prevention of falls among frail older home care clients. So the main objective of our second study was to determine the effects and costs of a 6-month multifactorial and interprofessional team approach to fall prevention compared with usual home care for older home care clients at risk of falling. The setting for this study was the Hamilton Niagara Halderman Brant CCAC and the Mississauga Halton CCAC. Our study population consisted of 109 older home care clients who were 75 years of age and over, eligible for personal support services through the CCAC, and again, they had to be competent in English, living at home in the community, mentally competent to give informed consent. They also had to be identified as being at risk for a fall, which meant they had either fallen in the last 12 months, expressed a fear of falling, or were unsteady on their feet. And this study occurred over a period of 2 years, and those clients who met the eligibility criteria and provided informed consent were randomly assigned to receive either the interprofessional team approach to fall prevention or usual home care. The interprofessional team approach to fall prevention was a multi-component intervention that consisted of the development of 2 specialized interprofessional teams consisting of a nurse, a physiotherapist, a dietitian, an occupational therapist, and a case manager. And the team provided structured and planned home visits to these clients over 6 months. And during the home visit, they screened people for known risk factors for falls using standardized screening tools, and then implemented multifactorial and evidence-based strategies for fall prevention. The team used motivational interviewing or motivational strategies to promote behavioral change for risk factors in order to reduce risk factors for a fall. And they also met regularly and had team conferences to discuss the results of their finding as well as to assess the clients on an ongoing basis. And through that team conference, the team developed a single evidence-based interprofessional fall prevention plan. As well, they referred clients to other community health and support services. And we developed really 2 teams, one within each of the catchment areas of the study regions. In this particular study, the primary measure of effect was number of falls during the 6 months, and that was measured through self-report. And if clients fell, we contacted them and obtained further information on the circumstances of their fall using the fall surveillance report, which we developed as part of our study. The secondary measures of effect were known risk factors for falls, and that included, again, health-related quality of life, cognitive status, depression, gait imbalance, nutritional status, environmental safety, as well as perceived efficacy, self-efficacy. And again, we also measured the cost of use of health services from a societal perspective. And all of these outcomes were measured at baseline and again at 6 months immediately following the intervention. So in terms of results, what we found was that compared with the usual care group, the multifactorial and interprofessional fall prevention intervention resulted in a greater reduction in the number of falls among men, particularly men who were 75 to 84 years of age, with a fear of falling or a negative fall history. It also resulted in a greater reduction in the number of slips and trips in the sample as a whole, and a greater improvement in the SF-36 role emotional score, which suggests that there were improvements in health-related quality of life related to emotional or mental health. And again, even when the cost of the intervention was added to the total cost, there was no significant difference between the groups in the total per person cost of use of health services at 6 months. So in other words, the intervention cost the same as usual care group. Our final study looked at interprofessional stroke rehabilitation for stroke survivors using home care. So although many advances have been made in stroke prevention and management, stroke continues to be a prevalent and burdensome condition, particularly among older adults. Stroke is considered to be the leading cause of adult disability and the 3rd leading cause of death in Canada. And at 6 months after a stroke, about 80% of stroke survivors will be living at home, and 83% of those people will have less than optimal recovery requiring further rehabilitation at home. Yet there's very little information about the best way to provide community-based stroke rehabilitation for stroke survivors using home care. So our research objectives, therefore, were to determine the effects and costs of a 12-month specialized interprofessional team approach to community-based stroke rehabilitation compared with usual home care services for stroke survivors using home care. The setting for this study was the Toronto Central CCAC, and our study population consisted of 101 stroke survivors who had a confirmed diagnosis of stroke, so it could be their first stroke or a recurrent stroke or a TIA within the previous 18 months. They had to be eligible for home care services through the CCAC, and again, they had to be living at home, competent in English, and mentally competent to give informed consent or have a substitute decision maker. The study took place over a 3-year period, and eligible and consenting clients were randomly assigned either to receive the specialized interprofessional team approach to stroke rehabilitation or usual home care. Again, this was a multifaceted intervention, and it consisted of the development of 5 interprofessional teams within the Toronto Central catchment area. And these teams consisted of a case manager, a nurse, a physio, an OT, a speech-language pathologist, and a dietitian, as well as a personal support worker. And the teams provided structured and planned home visits to the stroke survivors over 12 months. And during those visits, they provided comprehensive in-home assessment of factors that influence community reintegration and stroke risk factors using various screening tools. The team also provided education as well as strengths-based practice to empower clients and promote positive behavioral changes. They provided support to the caregiver as well as met regularly to discuss the clients and the results of their assessments in order to develop a single evidence-based interprofessional community reintegration plan. And the team also referred clients to other health and social services. So our primary outcome for this study, again, was health-related quality of life. Our secondary outcomes were included the number of strokes during the 12-month follow-up, anxiety and depressive symptoms, social support, and community reintegration. And again, we measured health and social service utilization over a 12-month period from a societal perspective. The outcomes were measured at baseline and again at 12 months following randomization, immediately following the intervention using the structured in-home interview. So the results, what we found with this study was that compared with the usual care group, interprofessional stroke rehabilitation resulted in greater clinically important, although not statistically significant improvements in the mean SF-36 physical functioning and social functioning score, suggesting that there were improvements in both physical and social functioning. And even after the cost of the interprofessional team approach was added to the total cost, there was no significant difference between groups in the total per person cost of use of health services during the 12 months. So again, both interventions cost the same. So those were the results and just a brief overview of each of the studies. So what I'd like to do now is just talk briefly about what did we learn as a result of conducting these 3 trials. So first, what we found was that for frail older home care clients with varying characteristics using home care services, nothing is more important, expensive than on-demand and fragmented services. And as a collective, these studies really add to the accumulating evidence in our Canadian healthcare system that for frail older adults with multiple problems, proactive, comprehensive, and integrated nurse-led health promotion is more effective and no more expensive than usual home care. And what we also found was such an approach is feasible and acceptable from the perspective of the end users. So that is both the clients, their families, as well as the healthcare providers. In each of our studies, we conducted an economic evaluation, which involves a comparative analysis of alternative courses of action in terms of both costs and consequences. So across the 3 studies, we used a framework, which I'm showing you here, to classify the main effects and costs of comparative community health interventions, with the overall goal of maximizing improvements in health using a fixed pool of available resources. So looking at this framework, there are 9 possible outcomes of economic evaluation of health programs. The more favorable outcomes are highlighted in the triangle. In outcome 1, we see increased effects or health benefits are achieved with increased cost. And this is called cost effective, where we see more effect achieved for more cost. Outcome 4 is also favorable, where we see increased effects with one approach over another at the same cost. Outcome 7 represents the win-win situation, or the unambiguous improvements in economic efficiency, where we see more effect produced at lower cost. So that's really what we call a win-win situation. And outcome 8 represents a situation where alternative healthcare programs produce the same effect, but some approaches are associated with lower cost. Of course, options 7 and 8 are superior to the often implemented option 9 we often see in healthcare, where funding is cut along with the potential for reduced effects. So in terms of our three studies, it lands really in outcome 4, in which we found that the interventions were all more effective at no increased cost. And these studies we also found support and extend the literature regarding the features of successful community-based health promotion programs for frail older adults. So what we found overall was that the most effective nurse-led health promotion programs need to include a specialized and coordinated interprofessional approach, comprehensive in-home assessment of known dimensions of frailty using standardized screening tools, regular follow-up care with flexible delivery based on client needs, intensive case management, and multi-component evidence-based strategies that target the dimensions of frailty but are also tailored to individual needs. Application of behavioral change strategies was also very important in terms of enhancing adherence and promoting positive behavioral change. And early access to appropriate services, referral to and coordination of community services, and also a recognition that we need to take a very much of a family-centered approach to care and address the needs of family caregivers as well as the older home care client. The allocation of home care services to date has been largely based on physical or medical needs, on the apparent assumption that non-medical services are unrelated to health outcomes. On the contrary, what we found from these studies is that comprehensive and coordinated services aimed at all of the determinants of health are superior when compared to individual, fragmented, and disease-oriented approaches. And that the promotion of healthy or successful aging really requires a holistic approach. That interventions that address single problems or single diseases or risk factors are less effective and will be less effective in improving health outcomes among older adults who have synergistic and multiple problems. Successful health promotion interventions also need to be tailored to individual health needs, because no single intervention or mix of services will meet the needs of all seniors. So by doing subgroup analyses in these studies, we found that it's very important to classify who, with what characteristics, most benefits at what expense from various interventions, especially in our system of national health insurance, where people will use, however appropriately or inappropriately, some services if another service is made unavailable. The implementation of effective health promotion interventions really involves changes in attitudes and behaviors at a number of levels. First, older adults and their families often don't think that they are at risk for a fall or depression and may not be ready to implement changes in their behavior to address these risk factors. Healthcare providers involve changes in practice behavior, integration of evidence into practice, and really shifting away from the focus on the treatment of physical problems to a more holistic approach focusing on health promotion and disease prevention. Organizational changes need to occur to support the integration of evidence-based strategies and to promote and to endorse the focus on health promotion and prevention. Policies and standards are needed that support the development of basic competencies in health promotion, as well as the allocation of appropriate resources for the assessment of risk, as well as the delivery of health promotion strategies. In essence, really implementing these interventions, which focus on health promotion, was really more about changing the system as it was about changing individual or client health provider practice. So in summary, we found that home care has the potential to play a key role in mitigating frailty and its adverse outcomes. And interventions that are provided on demand and address single problems or single diseases or risk factors are less effective in reducing problems or enhancing health than proactive, comprehensive, and coordinated health promotion, health-oriented interventions. So certainly the results underscore the need to reinvest in nurse-led health promotion interventions in home care to optimize health-related quality of life and promote successful or healthy aging at home for frail older adults. There's a need for a paradigm shift away from what we call a find it and fix it episodic approach to a find it and manage it and prevent it approach. The key to our sustainable Medicare system is a well-planned strategy that addresses the evolving healthcare needs of this vulnerable sector of the healthcare population. So there's a need for making strategic investments now in health promotion to mitigate the risk factors of frailty and loss of independence so that living at home, even with significant challenges, can actually become a true reality for older adults. So this final slide shows you all of the various studies and where they've been published, and so certainly if you'd like to access any of these studies individually, there would be more detail in these publications. Thank you very much.